Welcome to our annual Summer Roundtable series, Asterisk, addressing systemic and structural racism to improve safety, quality, and trustworthiness in health delivery systems. Asterisk is funded by the Agency for Healthcare Research and Quality. This summer's theme is awareness. We cannot address or change a problem if we do not see it. In this series, 2024, we will discuss the impact of racism and on health delivery systems and present opportunities to determine root causes of racial health disparities. The roundtable sessions will ask participants to diagnose structural racism and how it shows up in their health delivery systems and enables racial health disparities to continue. So the topic today is whole person care, and whole person care is based on the values and circumstances of each individual patient and addressing preventative and chronic physical, behavioral, and social health needs. Effective delivery of whole person healthcare is critical to optimize health and functional status and well-being, as well as critical to eliminate health inequities across the lifespan. This emphasizes the needs of older adults and children with complex medical conditions. So our roundtable members will discuss their experiences in patient, practice, community, and health system level interventions designed to improve access, quality, outcomes, and equity care. So I would ask our panelists to introduce themselves. Jason, I'll just start with you because you're at the top of the box. Please go ahead.
All right, great. Thanks everybody for being here. My name is Jason Falvey. I'm a physical therapist by training and a faculty member at the University of Maryland School of Medicine. I'm also the director of the Center for Disability Justice here, which focuses on intersections of disability and health disparities. And most of my work focuses on how to get people out of their homes and into the community after they experience a traumatic injury or a serious illness.
Thank you, Jason. I actually meant to ask you one more thing. If for all of our panelists as well, is share one goal you have for participating in today's conversation.
Oh, that's a great question. And I think my goal is to make sure that I convey how important your neighborhood is and your social environment, and those social connections you have are for your health.
Hi, everyone. My name is Kelsey Sala-Hamric. I am a senior research scientist and clinical psychologist at MPHI, the Michigan Public Health Institute. I'm also the director of the Michigan ACE Initiative, which is a cross-sector collaborative of organizations working to prevent and mitigate the impacts of adverse childhood experiences. One thing I would like to get out of today, most of my work is around supporting both systems as well as children, families, and communities in increasing access to behavioral health care and integrating behavioral health and trauma-informed programs into our systems. One thing I think I'd love for people to take with them from this session is just kind of an understanding of what our providers and our system should be doing for all of you. And kind of that's really on us to be thinking about how we can improve our systems and partnering with everyone, with all patients, stakeholders, everyone, but how those systems can really take responsibility for supporting whole patient care or whole person health.
Great, thank you, Kelsey. Jared?
Hello, everyone. Thanks for having me. My name is Jared Walker. I am in the Pacific Northwest. I run an organization called $4. We are a nonprofit organization that helps people relieve medical debt. We do this primarily through enforcing hospital charity care and financial assistance programs. So whole person health definitely, I would say, involves finances. I watched my own family go through this and, learned pretty quickly that when you have a medical emergency, a lot of times you have a financial emergency. There are programs available, like what we do is enforcing charity care, which requires hospitals to discount or even forgive your medical bills if you meet certain income requirements. And we help patients do that. We have been able to relieve over $56 million in medical debt for people throughout the country. And if I could leave one thing, it would be that. It'd be these resources that they are out there and how to access them. Because, yeah, you shouldn't lose everything because you get sick. And we see that a lot. So thanks for having me.
Hi there, I'm Joe Huang. I'm a family doctor. I've been a family doc for 25 years. I currently work for an organization called Physicians of Southwest Washington. We manage a number of services related to various CMS innovation models and other ways of connecting health systems and health providers with insurance companies. And so I'm very interested today in conveying some of this intersection between between public policy and in particular how Medicare is really the largest payer in the world and its policies and innovation programs impact how healthcare providers and health systems behave and how that really impacts whole person health and health equity.
Thanks so much, Joe. So to kick us off, what is whole person healthcare? I think some of you have talked about it, but if anyone wants to kick us off, how would you define that?
Maybe I'll start by saying what it's not. And so I'll contrast it with how healthcare services have been reimbursed historically in this country. And really, the traditional model of healthcare reimbursement is fee for service, which means I as a doctor or one of my colleagues does something to a patient, whether it's an office visit, a surgery, some other procedure for a medical condition, and then I get paid for doing that thing, right? In all of that, the focus really is just on doing stuff to people, right? It doesn't really necessarily encompass what do I need to do to keep that person healthy? Or beyond that, what do I need to do to take care of an entire population of people and keep them healthy? What are my incentives in that model where I'm paid to do stuff to people versus paid to take care of a population? I think it's pretty obvious that there's no really space there for thinking about more than just that person's immediate medical need. And so I think in contrast, whole person care is about recognizing that a person is more than just their physical or medical needs. It encompasses their any behavioral health needs, what their mental health looks like. It encompasses their social context, and not just of the individual, but all of the community around them and the history of the generations of those communities before them and how that impacts their current health and well-being.
One way I often describe this to patients is like when I work in clinics that have more of a whole person focus, like in the Department of Veterans Affairs, where I do some of my clinical practice, they have a lot of focus on whole person healthcare. And the way we boil it down, and I think Joe gave us a great explanation there, is doing stuff with people in collaboration with people versus doing stuff to people. And I think that's the whole person healthcare versus our current healthcare system is, doing stuff in collaboration with our patients and co-developing solutions versus doing stuff to our patients in reaction to some sickness or injury.
Yeah, and I think if you could talk a little bit more, it's not only the healthcare as you're both talking about, not only the patient-provider relationship, but some of the contextual factors for accessing care. So, what are some of those contextual factors that are important to whole person care, like structural barriers, transportation, things like that?
Yeah. And so, I think maybe I'll kick this off because I know I had put this plug in earlier. Transportation is one of the biggest barriers to getting the healthcare, right? Not having adequate transportation, not having somebody to give you a ride, or not being able to use the bus or the train or the trolley that you might normally use because you had a recent injury that made it more difficult to get on the bus or keep your balance. And I think those are factors that we often miss in those office visits. Is how did you get to your healthcare appointment? How can we help you bridge that gap? And sometimes that's just getting access to the transportation. And sometimes it's broader, as the sidewalk is cracked and I can't walk to the bus stop after my stroke. And it takes me much longer, or I feel less safe because I use a mobility device and my neighborhood isn't that safe. So we really have to think more creatively about solutions to address not just the immediate, I need a new medicine or I need to see the doctor, but maybe broadly about how do we bridge community gaps as well.
Yeah, I can kind of add to that in connection to this definition of whole person health as well. When we're thinking about someone's physical health, someone's emotional health, really just thinking about all of the different contextual pieces that kind of play a role and are integrated into what makes someone healthy or what makes someone well. Maybe well is the better word in some situations, because then we can talk about the integration of spiritual wellness, transportation, financial wellness, occupational wellness, and the integration of all of those things. One of the things I think a lot about, and we're trained in the behavioral health field, is don't make a recommendation that you know cannot be followed. Right. So if you're saying, oh, I want to refer you to such and such clinic, but you know there's no way, kind of as Jason was talking about with transportation, that a patient is going to be able to get there, we're not really able to care for the wellness or the health of that person, which I think also leads me into my own kind of area of passion to the integration of care and how important that is.
I think the only thing I would add is obviously I'm going to speak a lot about the financial side of this, but what you see happen a lot is when these things don't exist, what happens? People start avoiding care. They're fearful of the cost, or they are neglecting care because they don't have access or can't afford it, and which is something that we see all the time. I think I recently read 1 in 4 people in the US are just avoiding care because they're fearful of the cost, which is obviously a huge issue.
So, Kelsey, I mean, you were talking a little bit more about, this whole person, that's what we're talking about. But a bunch of your research focuses on healthcare models such as trauma-informed care, integrated behavioral health. Can you share how these models really exemplify whole person healthcare in practice?
Sure. I think there's two pieces that I like to focus on, and obviously integrated behavioral health models as well as trauma-informed care models can be implemented in different ways depending on the system. But when we're thinking specifically about integrating behavioral health into physical health systems, we're really thinking about improving access and finding ways for teams to collaborate with a patient, hopefully as an equal partner as well. The patient is actually the expert of their own experience. They can have different physicians, different behavioral health specialists, other types of specialists that might be needed, and being able to really provide access and a more comprehensive understanding of what that patient needs. I think that ties into trauma-informed care as well, as one kind of specific piece of the puzzle or piece I work on, around building trust and relationships with people who are coming and seeking services. We know that patients are experiencing trauma in many forms in their life, both within healthcare and without of healthcare. And we know that if we're a provider or if we're a healthcare system, we oftentimes are representing a lot of really difficult experiences that might not have had something to do with us individually, but a patient is coming from a place where they have struggled and they need care and they might not really feel like they can trust someone, right? So when we think about things like trauma-informed care, not only are we thinking about access, but we're also starting to think about building that relationship of trust back. And again, focusing on putting that person in the driver's seat, making them kind of the expert of their own experience and starting from there. And there's a lot more that goes into trauma-informed care, but that's a really nice starting point.
Maybe piggybacking a little bit on this notion of trauma-informed care and certainly of integrated care, I just want to, say that as a primary care provider, the experience of delivering care in a setting that you do have integration with behavioral health, it just feels so different, right? And I think that trust is a big part of that, because some of the notion of integrated healthcare is as the person who's mostly in charge of the medical aspects, although of course we're responsible really for thinking about the whole person, but being able to have a trusting relationship with the patient, then pass them off to a trusted colleague that I can introduce, who really specializes in those aspects of care, can make a big difference in that initial bridge, to establish a new relationship with a new provider in an area that can carry so much stigma and really impact folks' willingness to even talk and access care. And zooming back out to like, why does this matter for us? Certainly it matters for every individual that it impacts. Societally, this impacts us so much as well when we think about the economics of healthcare. The individual who is impacted by a behavioral health condition costs about 3.5 times more than somebody with just your traditional medical conditions. And if you layer onto that something like a substance use disorder, we're talking about 7-8 times the healthcare costs and expenditure. So this really matters at an individual level and more broadly for us societally.
Yeah, I love that too, that one of the things I always find, because there are sometimes difficulties to implementing integrated behavioral health care. There are barriers, there are things we need to work through as systems to make sure we can establish that type of program. But one of the things I think that Joe started to highlight as an important sell for these models is it really also helps providers do their jobs better. Right. So if you're a physician and someone is struggling with behavioral health symptoms, those two things are going to interact. It's going to impact the care you might want to recommend. It might impact someone's ability to engage in certain care. On the other hand, it also can kind of provide ways for providers of all types to support each other in working with patients who might need a lot of help. So just again, sometimes we think about these insurmountable challenges, but then once we've implemented them, I always hear kind of like as Joe was starting, how pleasant it is and how nice it is to have clinics or have environments where this integration has taken place, because we can all really support each other in that way.
And I been reading some literature, about this integration. And I think the question I would come to is, if you're a primary care provider, depending, we talk about rural settings of not having as many resources. Does a primary care provider, if they're not working at a big clinic, do they even know who they can refer someone to if it can't be in the clinic in the same building? Do they know who they can refer to that's a behavioral health specialist that's even in their insurance network, if that's possible? That is when we're talking about that, do primary care providers have the resources or the nurses to be able to connect to those other specialists, whether it's an oncologist, a nephrologist, psychiatrist, whatever, dentist, whatever it might be? Do they have those resources to be able to easily connect someone, even if they can't be in the same building?
I think part of what you're getting to, Joe, is so often the answer is not, right? Our care delivery system is so fragmented that often we depict this as throwing the patient over the wall. You throw out a referral and you hope someone picks them up on the back end, right? And that's why I think it's so important to have the structural payment incentives for systems to become more connected and to battle some of this fragmentation and disconnectedness that really, really impacts a patient's experience of the system.
Yeah, it seems just kind of letting it go on its own steam is, like, as you said, it's fragmented. So then everyone suffers from that. So let's talk a little more about access, specifically financial access, affordability. Kind of alluded to that with insurance coverage, things like that. So the U.S. healthcare system doesn't make it easy for patients and families to know the financial costs they may face, nor the resources available to them to help pay for care. So Jared, can you share your experiences in helping clients navigate these barriers?
Yeah, it's a complicated question, because the first thing you said is knowing what the price is. So which makes me think of, okay, price transparency laws, right? Hospitals are supposed to post their prices, and a lot of them are not. So then you get into what I mentioned earlier, people not knowing what it costs going in, so they avoid it because they're fearful of what it will cost. Because that's normally, unfortunately, that's one of the first questions that people, patients ask in the US. Well, how much is this going to cost? And if you're not able to get an answer, then a lot of times people will avoid the care. And then there are most of the people that are avoiding the care are going to be low income. They're not able to afford it. And that brings me to like the second point is a lot of these people are scared because they can't afford it. They're low income, which means that they would probably qualify for some of these programs like charity care, financial assistance, Medicaid. And, $4 obviously is focused pretty focused on charity care. And almost every single hospital in the country is going to have some type of policy saying that if you are within this income range, we will reduce or waive the bills. And a lot of people just don't know about it. And so the first thing is like education. We have to, we do a lot of trainings, even with healthcare workers, because a lot of times you mention this and doctors, nurses, they aren't even aware. So they're not able to tell patients about these programs. So how do we educate community about, these are programs that exist, and then getting into access. Even if you do know about these programs, a lot of times you are required to fax your information back to the hospital or mail that information, or it's not in the language that you need, or whatever it may be. So these are all things like that are pretty impactful. And we know that when people get charity care, when they are able to get that medical bill relieved, their lives get better. They report better health, better mental health, better food access. They can pay off other debt. They can save for their future. So this is a big part of whole person health.
Thank you, Jared. So Joe, we were talking about a little bit. So are there any payment systems or models out there that exemplify whole person healthcare and payer reform?
Yeah, I think that it's one of the important things, roles that CMS has, I think, is really testing programs that pay differently from the traditional model that I think I started out describing of just doing stuff to people for that immediate physical injury or illness, right? And so I think that a lot of the general principles that Medicare has been implementing over quite some time now, over a decade, really is how can we get health systems not to behave quite as much in this per click doing stuff to people sort of way of thinking, and just doing stuff for their physical needs. But how can we really increase incentives to think about what are the outcomes? What are we actually getting? Are we getting what we want and what we're paying for? How can we be a country that invests so much in healthcare and has some of the worst public health outcomes in the world, among the developed countries, right? So are we getting what we're paying for? And how can we incentivize and pay for quality outcomes? How can we pay for the actual cost of care for people? So instead of being incentivized for doing more and more expensive stuff to people, how can I be paid as a health system to be responsible for keeping a group of people healthy, right? And I think with some of the more recent models, there are some, I think, encouraging ways of aligning with health equity and whole person care. I think one example of this is making care primary, which really is an evolution from prior kind of primary care oriented payment models that CMS has put out and Medicare has put out. But really it highlights how can we pay a little bit more upfront for primary care, right? Because again, we feel that in a primary care setting, we're more likely to pay attention to all of the needs and the contextual needs of an individual, right? How can we attach incentives for those quality outcomes and for reduction of the total cost of care for folks. How can we support from a financial perspective some of the infrastructure for understanding data, understanding risk, understanding some of the social needs of patients? And so I think that that's one example. I think even a broader example is one of the more recent innovation models from Medicare is something called ACO REACH. So ACO stands for Accountable Care Organization, and REACH stands for Realizing Equity, Access, and Community Health. So again, Medicare is being very, very intentional about saying we know that there are structural drivers of the health disparities that we see and the health inequities that we see across the country. So part of this model is having health systems and groups of providers and health systems have requirements around a health equity plan to say, how are you going to be intentional about understanding the needs of your population, the health disparities that are being encountered in your amongst your folks, and what's your plan to address that? It even has adjusted cost benchmarks based off of area deprivation index, which is to say, we know in general that there are geographies where there is structural poverty and structural determinants where very large groups of people have worse access, worse health outcomes. How can we adjust financial incentives for folks that are trying to take care of more vulnerable populations so that there's a little bit more fairness, right? Instead of people just trying to cherry pick the more well-compensating populations of folks that they can take care of, right? And then it incorporates a lot of these other principles that I mentioned from the other model of how can we have prospective payment that supports primary care practice and integrates some of these elements of, gosh, am I going to use care management to address the whole person needs of a person, including some of their social needs, right? Am I going to be consistently collecting data about who a person is and their demographics so that I can measure differences in outcomes between different people and have an intentional plan about addressing inequities? Am I regularly screening for social needs of the entire population? Do I have connections with the community and other social services provider to be able to address the needs that are identified?
Thanks so much, Joe. So recently read 2023 literature review that was on trust and trustworthiness in healthcare. And one interesting finding was that a patient's trust in their doctor and their clinician did not translate to the patient's trust in the system or the organization that they worked at. In fact, and I quote, patients' lack of insight into what a hospital or health system's interests actually are. So, there's kind of that disconnect of the person you're directly working with and the organization they work for. So what are your reactions to this finding about that lack of trust? Jason?
Yeah, so I mean, I would consider myself a boots on the ground clinician who works face to face with patients on a regular basis, and I work for the Veterans Administration, where I often am helping patients through challenges navigating their system, and they can be frustrated with the system, but if you get them to buy into you as an individual, being invested, being a champion for them, helping bridge their needs, and like Joe said and Kelsey said, not just screening for their needs, but offering direct resources, names of people to contact versus just kind of a cold referral. I'm not surprised at all. And all it tells me is that we need more clinicians who look like or have the same lived experiences as patients so they can help them navigate these challenges even more. And I think that's a challenge across all of the health professions. But, I grew up in a very rural and low income area. So when I've worked clinically in those areas, it's easier for me to navigate those barriers or understand the community resources more than somebody who might come from an urban setting. And I think, that's one example of the many that we really need clinicians who have similar lived experiences or cultures as patients to help navigate those.
I'm actually really, I'm kind of surprised, I have to say, by this lit review, and I'm really heartened by it that we have a lot of patients feeling high trustworthiness in their individual clinicians. Oftentimes, one of the things in my work we run into is this feeling of clinicians needing to do a lot of that boots on the ground repair work in order to make that trusting relationship happen with patients, and that patients have, navigated systems for a long time, maybe run into lots of different ways in which they were trying to seek help, but did not happen, not because of any like malintent or anything like that, but just because of the system being complicated in the way it is. So the fact that we have these patients saying that they do trust their individual clinicians, I think is a really important, great start, and an important thing we should leverage and figure out how we can continue to use that trust. On the other hand, I do wonder too, as we are kind of building these really trusting relationships with patients, are we being honest about the health systems and what's the health system's limits and how to navigate that with them? And how can, again, I guess my question is, how do we leverage that trust to not be overly positive, but to find ways to actually connect them?
Thank you, Kelsey.
Yeah.
Yeah, I mean, kind of building on that as well, is what can systems do to be more responsible and improve that trust and trustworthiness? What is there to increase that trust and to build
Right.
on that trust that you are experiencing in those one-on-one interactions or the care team interactions?
And that's I think it's that balance too that I'm fortunate that I get to talk to a lot of really amazing clinicians who really care, but it's also like, make sure you're not over promising, right? Make sure you're not saying you're going to be able to get something covered if you don't know. Make sure you're not saying that you're going to be able to make this referral if you don't know you can. And so where is that balance, and how do we educate our patients or the people we're working with, and how the system actually is working, at least right now?
I think in some ways, this is also a symptom of the lack of trust that frontline providers have in the health systems that employ them, or that they're part of a network of as well. I think increasingly, as administrative burden and healthcare economics have pushed more practitioners into employed models, has made it harder and harder. And like, I think the way the ways in which healthcare has developed, and all the clicks and typing and things, everything kind of almost, conspires to take away the provider away from their patient, from the traditional, some of the good things about how medicine used to be, right? And you hear healthcare providers complain about all about that all the time, and patients as well. And so I think some of this, it's incumbent on health systems to really understand part of the needs of how do you care for your caregivers, and engage them in a way that they can cultivate those trusting relationship with their patients in the community, and I think that will transmit into better trust in the system in general.
We hear all the time, people are very pleased, very happy with the healthcare providers, and then that experience is kind of spoiled by the billing experience. And it's like, hey, this person saved my life, they saved my child's life, like, we're happy with the healthcare workers, but this was kind of, now we don't feel as good because we had this poor experience with billing. So I think a big way to instill trust is to make that experience better, and not be so aggressive in sending people to collections and suing patients. I think that is a big fear for a lot of patients.
Well, I think it's just a transparency issue too, of people knowing what's going on, and to Kelsey's point, that the doctors and the care team are transparent about what they can and can't do. I mean, they may want to be able to have that referral or have something covered, but to Joe's point, they're having to wrestle with whatever organization or healthcare system that they're a part of, or insurance network, whatever it might be. But I think it's that transparency of not being surprised, of knowing ahead of time, like, this is going to be difficult, but we're going to work on it together. We need to just we need to figure it out as we go along, because it isn't there. It is, as much as there doesn't seem that there's a lot of certainty sometimes when navigating the system. In addition to being sick, in addition to already not feeling great, then you have all this other kind of administrative to go through. So systems change can feel very overwhelming. What can be done on an individual level to address change? And Jason, I can kick it to you if you would like to jump into that, but anyone else can speak up as well.
Yeah, and so most of my career, I was a home care physical therapist. So I often felt like I, as an individual, could make big influences and kind of hopefully be a support to, let somebody age in place versus have to go to a nursing home, making, home modifications. And I think those influences, from individual clinicians are so important, but I think a system reliant on individual exceptionalism from clinicians versus, structural changes is probably not something I would recommend. I think exceptional clinicians often have to be exceptional because the system doesn't support their patients or support best practices for whatever reason. So not to discount the value of individual exceptional clinicians. I know there are several on this call, but I definitely think that individuals that are doing clinical practice can help individuals that are doing great clinical practice, that can partner with academia and help, how do I disseminate these great practices that I'm doing more broadly, and how can I benefit more patients? I think those are really valuable things. But keep doing what you're doing, exceptional clinicians, and but continue to tell your advocacy partners, continue to tell your academic partners how to better align the care and the research with the needs of your patients. I think those are great value that I've taken from working with exceptional individual clinicians.
I think one of the things, and we are all academic researchers, patients, clinicians are all really already overwhelmed doing all of their work and their jobs. But one of the things I think that is important to remember is that many times we do, kind of as Jason was saying, we have different programs, different treatments, different system changes that have been tested and are evidence-based, and that a lot of really amazing researchers and clinicians and their patient partners have studied. And in the work I do, and what we see in implementation science research all the time, is it takes on average 17 years to get something that's going to be effective into actual clinical settings, if it's in clinical settings at all. And so I put that out there as just kind of a flag that if there are ever opportunities to get involved in advocacy, advocate for those evidence-based things that we already know work, whether or not it's at being involved in a patient panel at a health system, or whether it's involved in, some sort of public policy, or, a chance to talk to an insurance board. I think we can all kind of try a little bit harder to think about how we can advocate for the things we know that's working. Because that's the really sad part. We have a lot of these things that we could put into practice, and it just takes a long time. And advocating where we can and using our individual voices where we can might make a little bit of a difference, and we can go a little bit farther.
Great, Kelsey. Thank you. Jared or Joe, if you had anything you'd like to share on that.
Maybe I would just add, advocate for yourself. Advocate for your family and the folks around you. Sadly, I think in the system that we're in, it requires an element of self-advocacy to be able to highlight what needs are going on for you and those that you love, and to hold your care providers and the health systems accountable for the things that they should be doing for you, not just in the moment, but for you as a whole person and all the things that you have going on.
I love that, Joe. I think, yeah, what I would add is it is very unfortunate that we have to kind of become experts in helping, navigate, help people navigate through this complex system. I think with when it comes to cost and I have helped a lot of family members fill out these applications, getting to know, be familiar with the income thresholds at your local hospital so that you can, direct people in the right direction, can change somebody's life. And I think one other thing I would add is there's a lot of shame with medical debt or any debt. And I think that there is a level of just encouragement and like coming alongside someone and letting them know that this has everything to do with a bad system and nothing to do with you being financially irresponsible, or people don't choose to take on these healthcare costs, but there is a lot of shame associated with needing the help, applying for financial assistance. Even the term charity care, it can be a barrier. And I think we should be encouraging people that, it's not, because you should have no shame in that.
Thank you, Jared. Thank you, everyone, for those responses. Had one a Q&A question, and for Jason. So Veterans Affairs has been doing whole health for a number of years, and there's a 2023 report about the experience. Can you talk more about how that works, the VA, and whether it could serve as a model for other health systems?
That's a great question, and I don't think I could do it justice in the time we have, but I can briefly say yes. The National Academy of Medicine, which is a very large organization that reviews research, evidence, and different innovative practice models, and kind of makes broad recommendations about how we should approach different challenges in healthcare. And whole person healthcare is something that they strongly endorse. The VA does this in many different ways in terms of integrating, primary care, behavioral care, making those, those connections a little bit more seamless, and making sure that those screenings and referrals are made regularly. But they also do things like spiritual screenings. Do you have spiritual needs met? Are you having housing insecurity and food insecurity? And those screens are done on a regular basis, and there's case managers or caseworkers assigned to help navigate the barriers. In the clinic we work in, we screen for transportation barriers and help people with paratransit applications or handicap placards if they need something like that to allow them to be more independent. And it's aided by the structure of a clinic, where we don't necessarily have to generate revenue as the primary goal, but it's to serve the veterans, which is a huge advantage to being able to do that work that many others don't have. But the VA has, not just said that that's their culture, but they've changed their electronic medical record and changed their systems and structures and added these required screenings. And, as many have said on this call, put the work in to identify resources or follow up on needs that are identified and not just leave them unmet.
Yeah, thank you, Jason. I thought that was something, I can't remember who brought it up, but there was someone that we've worked with that, their health system, they're collecting data when you go in, your social determinants of health, your housing, your transportation, do you have your phone? Can you connect if you need Wi-Fi, whatever it might be? But then there was and then she was asking the patient family council, in the hospital, well, what are you doing with that data? Are you then turning that into, we're now connecting people with resources, or is it just, we're collecting it, but we don't, as a health system, we don't know what to do with it? That comes to that transparency.
Yeah. And that can be more harmful than not collecting it at all at the end of the day.
Yeah, and another person talked about how to build that trust and trustworthiness. It's really asking the community what they want and need, what are the issues that they're struggling with. And also, someone asked the question about community health workers, patient navigators as people with lived experience, people that are in the community that can help with those connections. But also, is there a concern with being able to fund those positions, that those positions are valued and then funded more permanently in those health systems to help people navigate? I don't know if anyone's had any experience with those patient navigators, community health workers, and some of the work that they do. But it seems to be another way to help people make those connections and work in the system.
Yeah, absolutely. And I think at a policy level, the payment reform changes are in large part intended to be able to support providers and groups of providers like health systems to be able to fund positions like that, right? Because if someone continues to come to your ER again and again because they're actually struggling with substance use disorder or houselessness, that's something that, or some, or a less severe, social need, having somebody be able to shepherd an individual through some of those things and provide connections to community resources is crucial for keeping that person healthy. And when you align incentives so that the health system has skin in the game to be able to think of housing as health, or to think about some of these broader things, I think it does influence some of their behavior, maybe not as quickly or as impactfully as we would like them to always. But I think that there is, again, a directionally correct element to that.
Thanks so much, Joe. We're getting near our time here. So I guess I would ask our panel, what is one call to action you have for participants in today's session? And I'll actually start with Kelsey.
One, I feel like I've done some call to actions already today, but I'm gonna kind of echo like, it's not, it should not be a patient's responsibility to constantly be advocating for themselves. Right now, sometimes that's true, but I would encourage everyone to hold your health systems responsible. And if and however you can advocate for, better care, whole person health care, and get involved in the ways that are going to be a meaningful fit for you. We want to partner with all of you, and your experience is invaluable.
The accountability thing is big. Holding the healthcare systems accountable to, and I'm going to continue to talk about hospital financial assistance and charity care. Like, these are federal laws that are required. We have millions and millions of people that are on payment plans or declaring bankruptcy for bills that they don't have to pay. And hospitals should be sharing this information. And I believe, obviously I will do a quick plug for $4 as well. We are a free service. We can help you apply for charity care and lead you through that process. So hold your systems accountable, and if you need help, we are here.
I think my call to action, it will be similar to how I started in terms of, neighborhood environments are an incredibly valuable resource, and providers should know the neighborhoods that they treat in very well. Everything from the transportation system, they should know the community resources, or somebody on their staff should know not just that there's some clinic across town that does this, look it up, but a specific name of a clinic or a resource and a person, or an opportunity to connect resources with people. I think that makes all the difference. There is something to be said for a white coat effect, and that white coat of somebody recommending a specific service, knowing a specific resource, and that doctor taking the time to connect with the community and really make that connection much stronger between healthcare and social resources. I think that really hammers home the importance of those connections for a health system, that physicians are taking the time to bridge those gaps. And at the end of the day, I think patients will trust providers more that know the community and the resources and the needs a lot better.
It is so unfair for an individual who's sick and vulnerable to have to advocate for themselves in the moment if you're in a space where you have the time and inclination and energy, systems are required to integrate patient voice, and different systems do it better than others, right? But find ways to get involved if you have the inclination and the energy and the resources to do so, and hold your systems, your local hospitals and health systems accountable for the things that they should be doing in this area, and vote. Get everybody to vote, because public policy matters. Even when it doesn't make change as fast as we want to see it, it matters, and it influences behavior at large scale.
Well, I'd like to thank our panel today. Thank you to all of you for participating, asking your questions. I'm sorry we didn't get to all of them. I'd also like to thank the Agency for Health Research and Quality. And a reminder, we have one more session next Wednesday, same time, same channel. But yeah, we hope that you will join us for that. And thank you so much. Have a wonderful day. And again, thank you again to Jason, Jared, Joe, and Kelsey for their great insights today.